So thank you for coming. For how many of you this is your nap time? All right, well, thank you. It is a good time to actually nap, and I'll try to keep you a bit more entertained. So we could try to make this interactive, and if you have a burning question right when I am saying something, you think it's wrong, or you have a clarification, go ahead and raise your hand and I will try to answer that. But there will be times where we're going to just have to get through because it's going to be, otherwise you won't get to the end of the presentation. So some of this is going to be just review for many of you because you've been patient, you know a lot about this, you've read a lot about this already, but there may be a few little kernels of wisdom here that may be of interest to you. So as all of you know, many of you have narcolepsy or have friends or family who have narcolepsy. All people with narcolepsy have excessive daytime sleepiness. Some of it may be sleep attacks. Some of it may be just that you are feeling like you're neither awake or asleep, or certainly not awake fully or alert. Somebody says, "Are you alert?" You may not even know what that means, right? I mean, what does that mean? Does that mean, in our world, I would say something like, if I put you in a dark room, laid you down in a cool environment with nice down blankets, would you fall asleep? Well, if you say yes, then guess what? You're not alert. You're really not alert. You may be awake, but you're not necessarily alert. Cataplexy occurs in about 50% of patients with narcolepsy. When I started in this area of sleep disorders, I was not really an expert in narcolepsy. I thought cataplexy was rare in people with narcolepsy. We think it's rare, and most sleep doctors think it's rare because we're not asking about subtle manifestations of cataplexy. We think it's like the videos on YouTube, right? You fall and you're like, it's just dramatic and very severe severe cataplexy. And you all know what that is, but I think it's really important, at least for physicians and others, to really remember that even when you present, let's say, at a certain age with excessive sleepiness and you don't have cataplexy in this slide here, you can see from this data, can develop years later. So your doctor should be always asking about the possibility that you may have cataplexy because it can occur years later. And you can see over here, right? And we're even talking time after onset of sleepiness. Sometimes it's up to 10, 20 years you may not develop cataplexy. And this is really important because, as you'll hear a little bit later, is narcolepsy without cataplexy really narcolepsy? Is it a different kind of narcolepsy? And I think we may be missing that if we're not asking that. Of course, hypnagogic hallucinations. How many of you have hypnagogic hallucinations? How many of you told your doctor about the first time you met them? Which doctor? Yeah, sleep paralysis. But they're so bizarre, right? You almost don't want to tell anybody because they may go like, "You really?" They may think send you to a psychiatrist. Vivid dreams and also sleep paralysis. Sleep paralysis can be manifested in many different ways. One of the things that's really interesting is between when you think about hypnagogic hallucinations and sleep paralysis, is this kind of floating sensation sometimes that patients experience. They're looking down on their body and they're seeming like they are floating, but their body can't move. So it's kind of almost like a hallucination with sleep paralysis being mixed. And just imagine thinking about having out-of-body experiences. If you're telling your doctor about that, they may actually think, "Oh, this is," or they will ignore it. Maybe they won't even ask you any more questions about it. So something that I think it is. The other thing is that there's a strong association with increase in body mass index, and I heard earlier that Xyrem can be associated with weight loss, but in general, it is a weight gain. So you can imagine that many of these patients, because you're sleepy, get misdiagnosed or just diagnosed with obstructive sleep apnea, right? Because you're overweight, everybody snores, a lot of people snore, and so that diagnosis of narcolepsy is delayed because we're misdiagnosing, or at least we're not considering narcolepsy as part of the differential diagnosis. And also, when I was younger, which I am quite old now, but when I was younger, I used to think, what do you mean narcoleptics don't sleep? Or that they have disrupted sleep? I thought they were sleepy all the time. And so this is something in more recent years that we're beginning to appreciate, that sleep is also disrupted during the night. There are multiple arousals. Deep sleep is less seen in patients with narcolepsy. So that's really important, because that gives us the ability to think about, let's improve nocturnal sleep as a way of also improving daytime wakefulness and daytime alertness, which is something that we weren't thinking about 20-some years ago. We're mainly trying to keep people awake during the day and forgetting this. And this is why, in some ways, something like Xarm is actually doing a little bit of both, right? I mean, it's really also improving nighttime sleep, which is something. And you'll see why that is. And this is just an example of somebody with a normal sleep. Up here, you can see the REM sleep is in, about 90 minutes to 120 minutes after you've fallen asleep. Whereas if you look at somebody with narcolepsy, what do you notice? One, it's a 24-hour problem. It's not just a sleep or wake problem. It's a 24-hour problem. You're napping here during the entire day, or sleepy during the day. It's also broken up, and also REM sleep can occur very early, as soon as you fall asleep, or within 15 minutes of falling asleep. And look at these raggedy, looks terrible, right? All these frequent awakenings, frequent arousals. And so not only is sleep, you're sleepy, there's sleepiness during the day, but it's really broken up. It's almost like the brain can't either stay awake fully or stay asleep completely in this 24-hour period. And indeed, there are several studies now that show that there is a big difference. Patients with narcolepsy have 4 times more number of awakenings than a person without narcolepsy, and approximately 3 to 4 times more of the number of awakenings. And that doesn't mean like you're just moving a little bit. That means that you're actually aware that you are awake for at least a few minutes and perhaps a little bit longer. Not only do you have more sleep fragmentation, awakenings, but also there are changes in the type of sleep that you're getting. Remember, there's REM sleep, and there's non-REM sleep, and there's deep sleep, which we call N3 sleep, the deep sleep. And that is what's noticeable, most noticeable in people with narcolepsy, is that deep sleep, that N3 sleep, the sleep of babies, right? That babies have a lot of, is decreased in patients with narcolepsy. This is thought to be, in many ways, the most restorative type of sleep. This is a sleep that controls metabolism. This is a sleep that improves learning and memory, all the good stuff about sleep. Decreases inflammation. All of these things are occurring in this very deep stage of sleep, of which narcoleptics have a little bit less of. So therefore, the metabolic changes that are seen with narcolepsy, the mood changes are seen with narcolepsy, the inflammatory changes, all of these may be actually related to this alteration in the nighttime sleep, which is something that we have not really thought a whole lot about. What are the symptoms that we just talked about earlier? The hypnagogic hallucinations, the daytime sleepiness, some of those. We can kind of conceptualize this in this little circle here that I have. So the sleep disruption that you have at night is wakefulness intruding into sleep, unstable sleep, right? The sleep intruding into wakefulness is why you're sleepy during the day, is the excessive daytime sleepiness. And then all of the hypnagogic hallucinations, sleep paralysis, cataplexy, these are phenomena that are occurring because of the instability between wake and REM sleep phenomena, REM sleep intruding into wakefulness, right? Wakefulness sometimes intruding into REM sleep. This is why you get sleep paralysis. You're kind of waking up a bit. You're maybe still a little drowsy, but you still have REM sleep paralysis occurring while you're awake. So this is really, I think, narcolepsy, if you can think about it, is a condition of the instability of both wake and sleepiness, as well as REM sleep intruding into wakefulness and wakefulness intruding into REM sleep. So it's really a very unstable state that can possibly explain many, many of these symptoms. Furthermore, patients with narcolepsy have many other comorbid conditions that can make them sleepy and certainly decreasing. Obstructive sleep apnea is more common in patients with narcolepsy. More leg kicks during the night. Restless legs can be seen more commonly as well. And I don't know how many of you have REM behavior disorder, but this is, again, a REM phenomena that is occurring where normally in REM sleep, you can't move, at least intermittently. So imagine your last dream that you had, and imagine if you could physically act that out, right? You don't have to tell me what it was because I don't want to hear about it. But just think if that would happen. It could be dangerous for some people, punching, there could be falling out. And patients with narcolepsy actually also have a higher incidence of this REM behavior disorder, which you typically only predominantly see in older adults with, for example, with Parkinson's disease. Sleepwalking, sleep terrors, so all of these kind of unstable states may be seen. We talked about obesity, and I think it's really important to highlight the issue of mood disorders and depression. Is it the chicken or the egg? But I think there's data to suggest that it actually is bidirectional. It isn't just because you have narcolepsy that you're more depressed, but there may be a biological association between those two. So you can see how complicated it is to kind of really, for a provider, a physician like myself, to really treat a patient with narcolepsy because it's got many, many dimensions and it can be quite complex. And optimal therapies we'll talk about does require us to really look at all of these aspects. If you look at comorbidities, that means like comorbid other disorders that narcoleptics have in addition to narcolepsy. It's hard for me to read here, but you can see this in blue is the narcolepsy patient, and then in the gray is the control. So you look at nutritional problems like obesity, much higher in narcolepsy. Headache and migraine. How many of you also have headaches and migraines? Wow, look at that, double the amount of the general population. Mood disorders, whoa, more like 70% of that. Hold that thought for a moment. Anxiety disorders, depression, sleep apnea. Wow, no wonder doctors are confused and they diagnose you with sleep apnea because you have sleep apnea, right? But doesn't mean we should stop thinking. I always actually say the worst diagnosis anyone who's sleepy can have is extremely mild sleep apnea. Because then you get treated and you don't get better, and then they're going like, well, you need to use it more. And they get more sleep studies, and they keep titrating you with your CPAP, and we tend to forget, because once you have a diagnosis, you tend to forget the other possibilities. But you can see these comorbidities are very, very high, and all of these factors need to be addressed. These symptoms that you have in narcolepsy have a huge, huge impact on your functioning, and it's a health burden. People with narcolepsy, if you look at their the burden of narcolepsy, is very similar to some of the most devastating chronic illnesses that we have, that we think about are really bad. So you have impaired activities of daily living, whether it's cataplexy or excessive daytime sleepiness, impaired social, occupational functioning, especially in the younger adults and adolescents. I mean, this is a huge problem. I just had a patient the other day who said, who's 16 years old, and she said, well, I didn't know I have narcolepsy, because she had cataplexy. She would walk around the walls in her hallway, because if somebody made her laugh, she would have cataplexy. This is how she would walk in the hallways of her high school so that she could hold on to herself and not fall or not show. I mean, it's really, imagine that, having to be worried about that and the kind of effects that may have on a long-term basis. So it's really, really tremendous. So why this kind of state of instability of wake and sleeping and sleep? Well, a lot of it, I think, could be explained by the pathophysiology, at least of narcolepsy with cataplexy. And you heard this over and over again, I think even this morning, about the orexin system or the hypocretin system, exactly the same word, just different people. The sleep people like to call it hypocretin because Emmanuel Mignot coined it hypocretin. But the rest of the world really calls it orexin, but that's okay. It's really the same thing. And you can see that there's a lot of these orexin or hypocretin neurons in a control person in the hypothalamus, in the area of the hypothalamus, whereas in the narcoleptic, there is loss of that. And for your symptoms to actually show up, you probably have lost more than 80 to 90% of those neurons already. So that's part of the problem, is how can we figure this out a little earlier before people have lost all of these neurons. So by the time you present and you get diagnosed, you've lost most of these neurons already. So it's really decreased levels. The loss of these neurons are producing this neurotransmitter. There's a lot of data that's probably, at least mostly in part, an acquired autoimmune disorder. It could be a strep infection. It could be mono, which precedes it, or some unknown upper respiratory type of infection that may precede this. And for some reason, one's body ends up attacking their own neurons. And why this little bunch of cells, in the lateral hypothalamus is, again, a big mystery. But it's really, really interesting that this is probably what's happening. And you will get lectures on the H1N1 vaccine and the association with that. So there's clearly, in many cases, at least some kind of precedent, infection or perhaps some type of inflammation. There are genetic contributions as well, but the genetic contribution is probably more a vulnerability issue rather than the gene is truly being passed on. Because when you look at families, it's really, if you have narcolepsy and you're really worried whether you're going to be passing this on to your children, it's actually not that common. It's only about 2% or so. So when you lose these neurons, these hypocretin levels or orexin levels in the spinal fluid are very low. Look at these in patients with narcolepsy. It's generally less than 200 or less than 110 over here. Whereas if you look at patients with narcolepsy with cataplexy, it's much, much lower, and those control groups. So one could argue that perhaps narcolepsy without cataplexy is just another form of narcolepsy with cataplexy, that they may share the same pathophysiology. And maybe is the first slide, we just have to wait long enough, and maybe some of these people will begin to be diagnosed also with cataplexy. So I don't know how you were diagnosed with this, but currently, what's an update is that there are two ways that your physician or your doctor can diagnose you with narcolepsy. You can use the International Classification of Sleep Disorders, which just came out in 2013 or 14, or you could use the DSM-5 criteria, which is more what a psychiatrist would be using. But either of those can have some benefit. This is what most sleep doctors are using, and you can see there's type 1 and type 2. Type 1 is with cataplexy, and type 2 is without cataplexy. We chose to do that because it sounded like type 1 diabetes and type 2 diabetes, and type 1 was basically insulin, lack of insulin secretion, and type 2 was insulin resistance, so we thought that would be a cool idea. And type 1 is with cataplexy, whereas type 2 is without cataplexy. But using this criteria, your doctor is going to have to do either you can have a spinal tap. How many of you had a spinal tap? Very few. Because we can use that when we're really unsure, when the sleep studies here just don't really help us with that, or you're on medications that don't allow us to be able to do that sleep study. But there's only 1 or 2 centers in the country that will actually look at your spinal fluid results, and so it is still quite limited. There's no blood tests currently to look at these low levels because the levels are so low to start with. So in the ICSD-3, everybody needs to have a sleep study, a nighttime sleep study and a daytime MSLT, multiple sleep latency test. Everybody's had a multiple sleep latency test? Yeah. Whereas, And you had the CSF, right? Because you didn't have the multiple sleep latency test. And you too, right? Oh, as a baby. Wow, wow. Whereas in the DSM-5, if you have cataplexy, or if you have a low level of your CSF hypocretin, you actually don't have to have the MSLT. You don't have to have that sleep study. So this is the main difference between these two types of criteria. So when I can't get an MSLT because the patient's on medications and so forth, I may actually cheat a bit and use the DSM-5 criteria to be able to diagnose patients who I really believe clinically have narcolepsy for them to be able to get treated. So in summary, you all know about this, but really very important is to think about the nocturnal sleep disruption, something that we should be paying attention to. And then also, how many of you had HLA typing? That's a blood test to look for the a antigen. This is what people do before somebody has a transplant, to really look at autoantibody, to look at antibodies. This used to be done a lot among when I was younger. Again, we used to do this a lot because it's very, very highly positive in people with narcolepsy, but it is not specific. Okay, it is very sensitive, but it's not specific whatsoever. There are other disorders that you can see this, or no disorders at all that you can actually find this. But people who are HLA positive for this particular allele are also very likely to have cataplexy, as well. And we talked about hypocretin levels. Sleepiness, Epworth Sleepiness Scale, everybody's had that, right? So you know that. And what I think it's really interesting to look at is those patients with narcolepsy, right? Their ESS is like 18. This is really, really bad. I think the most you can get is 23 or something like 24? It's 24. So this is really, really bad. People with sleep apnea tend to be more like 10 to maybe 14 or 12, we would say is really severe. People with narcolepsy are much more severe as far as excessive daytime sleepiness is concerned. How many have heard of the Swiss narcolepsy scale? Huh, well, sure you. Good. There you go. So this is actually very, very, I think, in my opinion, an important clinical tool that we should be thinking about because it helps us get to cataplexy. It's very heavily weighted on cataplexy. So it's a screening tool. It's a very brief questionnaire that can be used. The purpose is to screen for a symptom profile that suggests narcolepsy with cataplexy. Remember, I said 50% of people actually have cataplexy, but we don't think it's that common, but it is. And here, let me show you what that is. So there are a couple questions they ask about inability to fall asleep at night. Can you imagine that? To fall asleep. Feeling bad or not well rested in the morning, getting to the sleep quality issue that many patients with narcolepsy have, taking a nap during the day, weak knees, so this is the cataplexy, weak knees, buckling knees during motion such as laughing, happiness, or anger, sagging of the jaw during emotion, so this is kind of the more minor manifestations of cataplexy, asking about that. And the method is basically a patient's self-report, takes a few minutes. Here is the actual website that you can actually get this and download this. It's very simple, SwissNarcolepsyScale.com. And you can input your numbers in there, and it'll spit out a score. And a score that is basically negative rather than positive. It's very simple. You don't have to go through this whole formula. A basic score, let me show you, that is basically negative, right, is highly suggestive of narcolepsy with cataplexy, and this is to differentiate people who have idiopathic hypersomnia or hypersomnia because it is heavily weighted on the cataplexy part. Okay, so a negative score. So this is something that is evolving in clinics, and we're really encouraging people to be able to use that. So let's talk about goals of treatment. You know what the goals of treatment are. You want to live as normal as productive of a life as possible, right? In every realm, in every aspect of it. So clearly then we need to reduce daytime sleepiness. We need to control the ancillary or some of the associated symptoms of narcolepsy, like cataplexy being probably the biggest one. And also these nightmares and hypnagogic hallucinations, sleep paralysis, they can all be very detrimental. And you can, although they don't cause harm necessarily to immediately, but if they occur frequently, they can certainly be another source of sleep disruption. Very important to improve psychosocial and work functioning and improve safety of the patient and also of the public. This is something that the Narcolepsy Network has done a lot of work in this area, and I think it is that takes it all. Even if we can make you a little more alert with your medications, if we can control cataplexy, we still have this big gorilla out here, which is the work environment, the safety environment, the social environment that most of the physicians, most of us are not even asking you about probably a whole lot. We're refilling your medications, right? And I think it's something that we certainly have to be thinking about more. So when I think about treatment for a patient with narcolepsy, one of the things that clearly comes out, well, what are the primary symptoms? How severe are any, not just excessive sleepiness, but also some of the associated symptoms like cataplexy, etc. What's the lifestyle of the patient? What do you do? You drive for a living? You're a truck driver? What do you do? That may help us with understanding how the type of medications, but also the scheduling of medications, the timing of medications across the day, can certainly be tailored to somebody's work schedule or social schedule. And is there any flexibility in their life? And if there isn't, it's amazing. I'll have patients who say, take a nap. No, I can't. My work will not allow that. Well, that may be the case, but we can help you with that. And I actually not had anyone turn me down when I wrote them letters to their HR and everybody else and tell them why this is so important, even getting 2 short naps in. One may not be enough, 2 short naps in. I've not actually had anyone turn it down. No company has ever done that because it's probably illegal for them to do it. But also, I think that they're cognizant. It's almost like we're afraid to ask, because we think, and if that helps you, that's really, really important. So even if it's not flexible, maybe we can help with looking at some flexibilities. Age and comorbidities, if you're older, you have high blood pressure, diabetes, and so forth, some of these stimulant medications may not be the option for you, and we may need to be looking for other types of medications, as well as psychiatric issues, depression. These are very important considerations as far as not only avoiding some medications, but perhaps there are some antidepressants that could also help you with your cataplexy that we may want to consider rather than something else, which may work better even like something like Xyrem. But if there's depression, there's other issues, we would want to certainly tailor those medications. So indeed, it is a multimodal approach. We talked about really assessing for all these comorbid conditions that we talked about already. Let's talk a little bit about sleep hygiene. Very important kind of to structure your nocturnal sleep and wake times. Regularity is essential. Going to bed and waking almost around the same time every day, in addition to weekends. And on weekends, I would say don't deviate more than 1 hour. Of course, got to give you some flexibility to party, but don't deviate much more than an hour because it isn't just how much sleep you're getting, but the regularity of that cycle for your circadian rhythms is very, very important. Structured naps, usually 2 naps can be quite helpful, even 1 if you can get away with it, if you can only get 1. And schedule it when you are most likely to be sleepy, according to your chronotype, according to your circadian rhythm. If you're an early morning person, your nap may actually be a little bit earlier. It won't be right now. You may already taken your nap, for all I know, before you came here. But if you're a later person, usually younger people tend to be delayed or later people. That may actually be occurring sometime in the mid or late afternoon. So if you only have 1 time to nap, choose it wisely where you're going to get the most benefit and where you may actually end up getting a little bit into deeper sleep. Light therapy. How many of you have been told to do light therapy? Wonderful. Well, all of you should be raising your hand because you walked out there today. Were you outside a little bit? Did you feel like you woke up a little bit? So light, bright light, has immediate alerting effects as well. So you're sitting at a desk, you're trying to work. There are a lot of these light boxes that you can buy or sit next to a window. But in addition to this immediate alerting effect, it can also entrain your circadian rhythms. It can make your sleep better at night and can increase your own natural melatonin at night, which is being secreted by your brain, by your pineal gland, if you have more light during the day, especially in the morning, but not, of course, at night, right? Of course, not after 9 p.m. or so. Regular exercise, very, very important. And then I think you have, there's some lectures on nutrition and diet, although, we can't all agree on exactly what it is, but in general, sugars, like refined sugars are not good because that can really increase glucose very, very quickly. But there are, like high fiber diets, lean proteins seem to be helpful, although there's very, very few studies really looking at this and randomizing this. Of course, there's the social factors, and here you are in one of the best narcolepsy support groups and network possible. And this is really important, especially with your local chapters. So, oops, I get so excited. So I see this. So sleep hygiene. Everybody knows about this. It's freaking boring. But I used to give my kids when they were little. Now my oldest is about 34 almost. And I used to say, hey, kids, I will give you like 25 cents to read the newspaper on Sundays and clip cartoons that are related to sleep for me, for my talks. And this is one of them, but I have no new cartoons because when they became teenagers, they wanted $5. So I have to keep using the same ones. It's boring. Everybody knows. How many times have I told you, no coffee after September, right? Well, it seems pretty obvious, but yet maybe many of us are not practicing. We talked about the regularity, getting that morning and or early afternoon exercise, bright light during the day being very important, no light or less light at night, avoid heavy meals, that's very important. Just with narcolepsy. Enhance the sleep environment. Make it cooler when you're sleeping. There's data to show that in patients with narcolepsy that having probably it says it's like your chest temperature should be about 35 degrees centigrade to 34.5. That enhances deep sleep. So deep sleep, that slow wave sleep that our narcoleptics have less at, could be manipulated by changing your body temperature a little bit. So temperature regulation can be important. I think I may have something about that. Yeah, temperature regulations can be actually quite important. So you want to be thinking about that as well. How many of you actually feel that you are more awake if the room is hot? If it's cold? Yeah. So there's this great study that shows from Uzven Sarman's group. Yes, you have a question? Yeah. Sure. Yeah, 300. Nothing. It's just usually they're like 300 milligrams, the caffeine pills. I mean, nothing really. The problem with caffeine is that if you use it more continuously, you develop tolerance to it. And there are also autonomic effects. Your blood pressure goes up, your heart rate goes up. So it's not something, and it's much less controlled. But there's really probably no big difference between drinking many Starbucks coffee versus taking the gum, the caffeine gum, or perhaps a pill. But let's talk about temperature regulation. So here's the study, right? Having something warm to drink, so you increase your core temperature warms up deep inside. Temperature warms up. Keep your feet and your hands cold. That actually increases alertness by almost 25% in the study in patients with narcolepsy. Okay? So little tricks that you may be able to do. I don't mean take ice packs with you everywhere you go, but something to think about. Or maybe just take your shoes off and your socks off, because it is the difference between what's your core temperature and your peripheral temperature that determines your alertness level. The opposite you would do when you are trying to go to sleep and sleep well at night. You want the core to be lower, right? And your extremities to be higher. So a warm bath or a hot bath before bedtime, pull on some socks can be quite helpful because that changes that temperature gradient. Again, this is something that I've always asked why we're not doing more of that, and I tell my patients to do that, and they seem to be helpful. So we did just touch about caffeine a little bit. These are some of the alerting agents, things to help you with your daytime sleepiness. Caffeine is a adenosine receptor antagonist. Very few studies particular in that, but clearly my patients, many of my patients use it. There are caffeine gums, there are caffeine drinks, there are caffeine pills that are available. But they do have side effects, okay? That's the whole problem. Caffeine can also have side effects. It's not without side effects. It can, and one of the problems is that it does develop some tolerance to it. And if you take it late during the day, the half-life of caffeine is quite variable among people. It could be a few hours or it could be up to 7+ hours. So that could be an issue. What we call the sympathomimetics, these are basically the medications that are like Ritalin, right? Like the amphetamine-like derivatives. This is a class that we call sympathomimetics because they increase dopamine, norepinephrine, and serotonin levels. Modafinil, many of you are quite aware of that. We don't understand the mechanism of action completely, but it probably still works a little bit and must be through the dopamine, because if you take rats or animals without dopamine receptors, it doesn't work as well. And there's the new ones that are being considered are histamine receptor 3 agonists as well as hypocretin or orexin analogs, which Dr. Thorpe spoke about a little bit earlier. I'm not going to go through all of these things because you clearly have gone through the gamut of what's treatment. These are what's approved or recommended by the American Academy of Sleep Medicine. And you can see the standard ones. Modafinil and sodium oxybate are standard. There's the greatest level of strong evidence that these medications work for excessive sleepiness, okay? Whereas the other ones are just guidelines or option, means that there's very little strong data to support it, but you can use it if we need to do that. What should we be careful about modafinil in women of childbearing age? It interferes and interacts with oral contraceptives. Okay, so it makes it so that if you're on modafinil, you need to use an alternative method of birth control as well, like a barrier type of method. It can cause serious rashes and allergic reactions. I was speaking to one of the mothers at lunch, and that's exactly what happened to one of her daughter. Her daughter was a serious allergic reaction, so we need to be telling our patients about that usually a lot of the time. Headache is another side effect sometimes of modafinil or modafinil. What about somebody like cataplexy? Clearly, the standard is sodium oxybate for cataplexy. I heard from all of you how well it works when when taken. And this is again, but is really a standard option for that. You can also use tricyclic antidepressants. We talk about Effexor. We talked about maybe like venlafaxine. Some of the older antidepressants, tricyclic antidepressants, can also be used, and they may have a benefit, especially if we also are concerned about depression, and so you may be able to treat both. So sodium oxybate can improve nocturnal sleep. It increases that deep sleep that we talked about narcoleptics don't have or go away. It reduces arousals and awakenings and can eliminate cataplexy, as many of you have already told me. It reduces vivid dreams, nightmares, hallucinations. It can reduce sleep paralysis. It doesn't fully control it. The tricyclic antidepressants actually do a better job at sleep paralysis than perhaps sodium oxybate by itself, and it can improve overall function. So if you choose one drug, I guess this would be the one, because it can improve, but there are many other issues with sodium oxybate other than the fact that it does work, right? Caution, in depressed patients, maybe associated with more depression, should not be used with hypnotics, depressant medications, definitely alcohol, and those who have hypertension. Salt is a huge salt load with sodium oxybate. There's a big salt load with this, and really has potential for respiratory depression in patients. If OSA is so common, so comorbid in people with narcolepsy, something to think about, but it can be used in patients who are treated for their obstructive sleep apnea. Not to mention that it is a scheduled medication and only available through a central pharmacy. So there are downsides, and you have to take it twice, as many of you know, during the night. And there are, things in the horizon that are coming down. So let's move now towards the, or actually, what is it? Yeah, okay. Let's move now to the new therapies, because I have now 1 minute. So CBT is something that you heard about this morning from Dr. Owens as well, why this is really important. We don't have narcolepsy-related CBT specifically. We've got to do it. I mean, we just talked about all of this. There's structuring. A lot of people also have insomnia symptoms. They may have difficulty sleeping. They may have difficulty maintaining sleep. So CBT for insomnia and hypersomnia should be developed, although we are doing this in little bits here and there. Non-hypocretin-based therapies are coming down. We have some novel monomergic reuptake inhibitors. We have some things that enhance that deep sleep that we talked about. And there are also some hypocretin-based therapies, like the analogs that we talked about. Stem cell transplantation, someone had mentioned that earlier in the earlier discussion. There's also some gene therapy. Now, there's some talk also about giving IVIG or steroids, but this only seems to maybe in case reports to work in people with acute narcolepsy, meaning you come in with this devastated narcolepsy, but how long are we going to catch it? It takes 15 years to diagnose it, right? So by then, it's already perhaps too late. Something on the horizon is this histamine receptor inverse antagonist called pitolisant, which is in trial right now, and you can see it can improve or decrease daytime sleepiness, improve alertness, but it is quite early. It is available in Europe, okay? So this is something for you to think about. Not in this country. In the United States, what's undergoing trial and almost finishing is phase 3 trial, is this compound called JZP-110. It is both a dopaminergic and adrenergic modulator, very similar to the sympathomimetics, but perhaps, at least in the phase 2 trials, perhaps a slightly safer profile from a cardiovascular standpoint. But of course, we have to see the results of it when it actually does come out. So these are two things that are in the horizon. Gene therapy, this is in the mouse. You can see that in the mouse, wild-type orexin knockout, when you gave the orexin gene back to the mouse, or you knocked out the orexin neurons, the gene, behaviorally, these mice they looked much better. They had improvement in their cataplexy. And finally, there are some receptor antagonists, orexin 2 receptor antagonists, because in patients with narcolepsy, the receptors are okay. the neurons are dying, but the receptors are okay, so you could actually use a specific receptor antagonist analog rather than necessarily getting orexin or hypocretin through the nasal cavity. So these are some of the things that are on the horizon. My time is out, so I guess there's no time for questions, but I think we've answered some of the questions as we're going along. I will be around so for the rest of the day, so ask me questions if you have any. Thank you.